This is going to be a slightly different talk than Brandon's, though similarly focused on cancer. We're going to zoom all the way out and work with epidemiology as opposed to basic science, so bear with me. The outline of this talk, well actually maybe I should just say exactly what we're doing. We're looking at I'm investigating the association between certain medications and pancreatic cancer risk in a case control study. So as an outline for the talk, I'm going to give a little bit of background about pancreatic cancer and why we should be interested in the risk factors for it. Talk a little bit about the case control study design, and then jump into the statistical modeling, which is the bulk of what I'm doing now. I know that's everyone's favorite, so stick with me through that. And I'll talk about a little bit of the preliminary data, and then the future directions for the project. So, the pancreas is here. It feels like med school was forever ago, especially clinical and medicine and surgical rotations. So, just wanted to remind everyone of the anatomy of the pancreas. Most pancreatic cancers arise in the head of the pancreas here. What I'm just trying to impress on you with this slide is the amount of important and essential viscera surrounding that area of the pancreas. So we have the duodenum, biliary structures, the portal vein, you've got the SMV and the SMA, the celiac axis up here. And you can imagine a cancer growing in this area could quickly involve some essential structures that may preclude resection. So now let's move on to pancreatic cancer. And like I mentioned, I'm dealing with the epidemiology of this disease, so we'll start with a little bit of background for the epidemiology. So over 45,000 American adults will be diagnosed with a new diagnosis of pancreatic cancer this year. And over the past 10 years of data accumulated by the American Cancer Society, the incidence is actually increasing, almost 1% a year for Caucasian men, women, African American men. The lifetime risk, about 1.5% Americans will develop pancreatic cancer at a median age of about 71. And histologically, about 85% of the disease is ductal adenocarcinoma, and that's what I'm focusing my study upon. So you may remember this from our lectures in M3. The American Cancer Society yearly puts out, for men and women, compiles a list of the incidence of different cancers and the cancer-related deaths attributable to each type of cancer. So pancreatic cancer is the 9th most common in women and the 10th most common in men, but it's the 4th most common in both women and men, the 4th leading cause of cancer-related death. So let's talk a little bit about the prognosis. So I mentioned a little bit over 45,000 new cases each year, but over 38,000 deaths per year. I already mentioned it's the 4th leading cause of cancer-related death, and mortality is increasing about 0.5% a year from 2000 to 2009. And that's in Caucasian men and women again. Pacific Islanders and some other ethnic groups, that rate is actually increasing by 1% each year. And this, unfortunately, dismal prognosis is at least partially attributable to the fact that 80 to 85% of these tumors are unresectable at first diagnosis. And so thinking back to that picture of anatomy we looked at originally, you can think of pancreatic cancer kind of in 3 ways. There's disease that's localized to the pancreas and potentially resectable. There's locally advanced or regionally spread disease, which is still contiguous within the pancreas, but involves, for example, the celiac axis or the SMA, and you can't resect it. And then there's distant metastatic disease. And as you may expect, survival rates are intimately correlated with the stage of the disease at first diagnosis. So localized disease, the median overall survival is almost about 2 years. Locally advanced is down to 1 year, and metastatic disease, median survival of less than half a year. Taking all comers, 1 year survival is only about 25%. To represent this slightly differently, the ACS also puts out these annual reports of the stage of cancers at diagnosis and their correlative 5-year survivals. And so I'll draw your eyes to the red columns. Green are Caucasians and blue are African Americans, but they're not significantly different. So just look at the red, which is all cases. So you can see amongst their data, only 8% of pancreatic cancers were diagnosed at that localized stage. Of course, if you were in that 8%, the 5-year survival was 23%. However, the vast majority were either had regional spread or were distantly metastatic, with 5-year survival rates of 9% and 2% respectively. So as I mentioned, all comers again, 1 year survival 25%, 5-year survival only 6% here. So this naturally leads into a discussion of what are the risk factors for this disease. But clearly we're not doing a very good job of catching the disease early, and we're paying for that with a very dismal prognosis. So what may potentially lead to a better screening program would be a better understanding of oncogenesis in the pancreas and what causes that. So these are the risk factors that are both well established on the left and on the right side, a little bit more speculative. Cigarette use is thought to account for 20 to 30% of all pancreatic cancer. Being older, African American, and a man is also a risk factor. Having diabetes, familial cancer syndromes such as BRCA2 mutations, certain types of pancreatitis and other exposures. And then on the right side, some surgical history, H. pylori infection, certain diet aspects, and then what I'm spending my year studying, certain medications are thought to modulate people's risk of pancreatic cancer. Interestingly, these three medications have some evidence preclinically and a small amount of clinical evidence that they may do so. Metformin and statins are thought to potentially decrease risk for pancreatic cancer, whereas NSAIDs and aspirin, there's conflicting evidence that they may increase or decrease. And since this is the first WIP, I wanted to sort of just take metformin, because that's what I've spent most of my time working with so far, and take you through the statistical analysis that I'm doing on that medication, specifically for an exposure of people who have ever used metformin versus people who have never used metformin. So to take you through how I'm looking through this database to see what the associated pancreatic cancer risk is with that variable. So let's talk about metformin. We know it as the drug that's most commonly prescribed to treat type 2 diabetes in America. Decreases hepatic gluconeogenesis and intestinal absorption of glucose, and importantly, increases insulin sensitivity in peripheral tissues. In addition to its anti-hyperglycemic effects, recent interest has also been accumulating in its anti-neoplastic effects. And the mechanistic explanations here, at least those most convincing, are that, for one, it mitigates the link between diabetes, which is a pancreatic cancer risk factor, and pancreatic cancer by decreasing circulating insulin levels. It actually decreases levels of free IGF-1, which is implicated as a pro-mitogenic event in pancreatic cancer. In addition, it directly inhibits mTOR signaling, which we've heard about now from Dr. Harris and Brandon, as linked to several types of cancer and cell growth, essentially. And so implicated in pancreatic cancer is the PI3 kinase AKT mTOR pathway. So there's a couple reasons, at least, to think that metformin may decrease our risk of pancreatic cancer. Actually, before I get into the case control studies, I just want to talk about clinical studies for a rare disease like pancreatic cancer. Don't, as we all remember from the DCR course and probably our M3 lectures, don't really lend themselves well to cohort studies or really randomized controlled trials. You need such a massive amount of patients and follow it for such a long time in order to accumulate enough pancreatic cancer events. So case control studies were designed for diseases with rare outcomes. You can grab, for example, 100 people with pancreatic cancer. Two published studies, Lee and Bodmer, and one published abstract, have looked at metformin use among other things, and I sort of isolated this data for us to see here. As you can see, the data is conflicting. In 2009, Lee, comparing anyone who'd ever used metformin to everyone who had not used metformin, showed a statistically significant decrease in the odds ratio. And as we recall, for a rare disease, odds ratio can approximate relative risk. So ostensibly, nearly 60% decrease in pancreatic cancer risk. Little found something similar, though it lacked statistical significance, and Bodmer found no significant association. Yeah?
Maybe there's subgroups based off of design. Is that what that was?
Yeah, so to get into, yeah, exactly. So Bodmer was a UK study in which they had, in the general practitioner's database, they've got prescription information. And so Bodmer looked exclusively actually at, you could almost call it like a dose response, or how long people had used metformin and saw any effect. They saw a decreasing trend, but the P for trend actually wasn't significant here, and none of these values are independently significant. Some of these studies did get a little bit into the duration effects, but in order to simplify this just for the one variable I wanted to talk about, I didn't present that here, but stay tuned for the next WIP.
And did Bodmer speculate why that group study was different from the other two studies?
You know,
in terms of, like, population?
It could be, I mean, so for Lee, this was done at MD Anderson, their controls were people who'd come into the visit with the patients, so often spouses that did not have pancreatic cancer, or neighbors, friends. Bodmer, they were able to select their controls from this practitioner's database with a centralized healthcare system in the UK. But beyond that, I mean, their populations weren't drastically different in really any way, so. No. All right. So now we move on to our UCSF clinic-based study. And this is a case control study that I'm working with. So just some facts. So we have 536 incident cases. We had a good participation rate, and 869 controls. The data in this study was gathered by one-on-one interviews with trained interviewers with the patients to collect epidemiologic data, and I'll get into exactly what they asked in a second. No proxy interviews were used, which means they didn't ask the questions to the spouse who answered for them. It was all directly one-on-one with the patients. To be a case, you had to have been diagnosed with exocrine pancreatic adenocarcinoma between 2006 and 11. And these patients were recruited from our medical onc and surgical onc clinics here with some supplemental data from the Cancer Prevention Institute of California and CPMC records. You had to be between 21 and 85 years old, and you had to live in San Francisco Bay Area County. And you had to be able to complete the interview in English. Same goes for controls, except for the diagnosis of pancreatic cancer. Control participants were frequency matched to cases in 5-year age groups and by gender. And for a final ratio of about 1.6 to 1 controls to cases. They were recruited at UCSF general medicine clinics, so it's screened in acute care across the street, primary care general medicine clinics down in Mount Zion. And some that weren't caught in the waiting room after their visits or before their visits were caught by phone afterwards. So, let me see if I can read it there. All right, so when patients were consented, they were given these scripted interviews. And this is basically a 35-page paper packet that the interviewer went through question by question. So I'll just give an example. When they got to this page, it said, before 1 year ago, did the doctor ever tell you that you had, and then they would come in here, diabetes? Yes, we'll put a 1 there. Was it type 1, 2, put a 2 there, diagnosed at age 45, and so on. And the responses were coded into a computerized database. If you had used a medication, we're specific to metformin now, so that's why I'm showing you these pages specifically. There's a large page on which metformin has a specific 2-digit code, and we also accumulate data on the ages they started, the ages they stopped, and the overall duration of use. And I should mention, this is sort of where I jumped into the project. These 35-page paper interview transcripts exist in a giant filing cabinet over at Laurel Heights. And while most of it was placed into an electronic database, some of it was a little bit missing or miscoded. And this is sort of where, back in June, I jumped in to try to make sure the online database was complete and correct. So, pertaining to these analyses for metformin, whether or not anyone had ever used it, their age started and stopped, overall duration was used. And the rest of the 33 pages that I didn't show you are all about data about potential confounders. So we matched on age and sex, but then other socio-demographic information, other exposures such as alcohol and cigarette smoking, their medical history, their surgical history, their medication use, their family history of disease as well. Anything that may potentially pertain to known confounders, like that one of those first slides I showed you, or potential confounders we don't know about yet. Yes?
I was curious, did you find that most of your participants know if they're on metformin or not?
Yeah, so of course I wasn't doing the interviews specifically,
Right.
But you can tell the amount of people that that weren't able to respond based on the missing data for any given variable. And surprisingly, I mean, of the diabetics, very few didn't know which medications they were on, and many of them were on them for a very long time. And so where some approximation came potentially was, I'm not sure which month at the beginning of 1996 I started on it, but especially with the form of all like metformin and its brand names, recall from what I can tell from the surveys is not as big a problem as I might have expected. But I mean, I should say that recall bias is inherent in any sort of interview garnered database, and that's why all the supplemental forms were used to try to minimize that. So this is part of our table 1. This is just some interesting information about our study. So we were matched on sex and age in 5-year groups, and this is condensed to be 10-year groups. Overwhelming percentage were Caucasian. Over half of cases were overweight or obese. and just under half were overweight or obese for controls. Over half of both groups smoked cigarettes at some point in their life. Over half were drinkers, but a significant minority were binge alcohol drinkers. And significantly more of the cases had ever had pancreatitis or a family history of pancreatic cancer. Yeah.
I'm just having a hard time figuring out how you did the frequency measure.
Yeah, so
if it's not 2 to 1 or 1 to 1, and how do you do 1.6 to 1?
yeah, so the way this is done is sort of there's continual meetings while the recruitment's going on, and you're looking at the balance of all these groups, so 5-year age groups and men and women, and then if you would say in the past week recruited so many men aged 50 to 55, they would then tell the interviewers, you need to go out and recruit more men aged 50 to 55. The reason that we don't do a specific 1-to-1 matching or 2-to-1 matching,
You just want the same number of people in that age group for cases of controls?
yeah, proportionally the same, exactly. If you do a 1-to-1 match and you are missing some data for one of the pair, both people drop out of your analysis, and so you can quickly start to lose your statistical power. But if it's frequency matched and you're missing one person, that doesn't necessarily mean if you're missing some data on this one control that you lose another case. And so in a situation where we're trying to maximize statistical power, frequency matching actually allows us more leeway there.
Okay, thanks.
Sure. Nope, sorry. All right. So we'll move on. So specific to these analyses, for type 2 diabetics, 170 of our participants had type 2 diabetes, and of those, 113 ever used metformin. On the right column here, we're looking at logistic regression analyses, but only preliminary data. These are minimally adjusted only for our matching factors of age and sex. And so preliminarily, it looks like diabetes may increase our risk significantly for pancreatic cancer, which is to be expected. And metformin also seems to somewhat increase our risk. But the next step is to go on and do full conditional analyses, and that's what we'll do next. So that leads us to logistic regression and modeling. And this was difficult for me personally, never having done statistics, even in high school. And you know how much we all love it, like I mentioned, so I needed to read this book cover to cover, which was an enthralling read. And then took a Coursera course, which I highly recommend if anyone's interested in stats. In addition, a Stanford MedX course, they're both free and easy to sign up for. And the Stanford course, you can go through at your own pace. And for example, regression analyses is unit 8. And if you didn't want to go through all the rest and you felt comfortable, when it comes time to do statistics for everyone's studies, I think that might be a helpful note. In any case, then I was able to code in stats. And this is the first macro I ever wrote. It's very near and dear to my heart. So this is what I spend a good amount of my time doing. And I'll sort of quickly, if I may, talk about how we go about building these multivariate models. So you start with a huge database of information, and then you sort of go through and you check to see if any of those variables have any significant association with pancreatic cancer risk, just independently, univariate analysis. And if they do, right, they're a potential confounder, because confounders are associated both with your outcome and your potential risk factor. And then, so you've got a narrowed down pool of potential confounders. Then you take your stripped down model, just sex, age, and metformin, and you input one of these factors one at a time in an iterative fashion, and see if it changes the point estimate of your odds ratio by some predefined number of 10% either way. If it does, it's a significant confounder and it stays in the model. If it doesn't, it falls out. And then when you've got a sort of an updated model with a bunch of new potential confounders, then you redo that process over again, and you may put more and more information into your model. So putting more information in your model could ostensibly increase your accuracy, but you suck up degrees of freedom with more and more things you're adjusting for, and so you lose precision, so your confidence interval starts to widen and widen. So the reason that we don't just put everything possible into the model is that we wouldn't have any statistical precision. And so by building this parsimonious model, things that aren't actually confounders in our data set fall out. And so we maximize our accuracy and our precision.
Do you know about the rule of 10?
Yeah, so you have to basically want 10 events for every variable that you put in. So that's something I'm going to get to actually, because that's sort of the limit as to how adjusted you can make a model. So I'll come right back to that. Unfortunately, it's not that simple. You can't just put things in, and if it moves your point estimate by 10%, keep it in. You have to do some thinking as well. So there are other statistical problems that may come up, and I'll use examples to describe these. So for collinearity, this is an example. If you input a variable that was the amount of time that someone lived in San Francisco, and it looked very significant, you might think, okay, there's something going on in this city, that increases our risk for pancreatic cancer. But then if you were to take the amount of time in San Francisco variable and their age variable, and saw that they're extremely collinear, right? You would just think, no, it's not that there's something about the city, it's just that people who are older have lived in San Francisco longer. And so that variable is modeling the same exact effect as age. And so you wouldn't double account for age in that situation. For mediation, this is something in which it has to do with causal pathways for your outcome. So if someone's obese, there's some thought that that may lead to an increase in pancreatic cancer. However, it's not totally clear whether there's some, for example, hormonal change with obesity that then leads here, or whether obesity leads to diabetes, which then leads to pancreatic cancer. And so there are more complicated analyses you could do to understand whether there's actually an independent effect, and that should be in the model, or whether it's just part of a causal pathway that diabetes variable is really accounting for. So you may or may not keep it in the model based on that. And lastly, effect modification. This is maybe the simplest. If you stratify your results by sex, and metformin increases your risk of pancreatic cancer in men and decreases it in women, right? If you were to have your database all together, you would see a null effect, but it's really just canceling each other out. So,
I think coming back to mediation, it's kind of
Yes.
important because if you say control for that mediator, you might lose the effect
right.
completely.
Yes, exactly. Good point. So now, with all that, it created a parsimonious model for metformin use. The exposure was ever use of metformin, and the confounders that stayed in the model were obviously our matching factors. These have to be in there. And then the patient's BMI, tobacco, diabetes duration, insulin, and we got this value. So a nearly statistically significant increase in risk with pancreatic cancer, with a point estimate that's quite impressive, 1.64. And this is counter to the previous results where it may decrease your risk or do nothing. And so it turns out that this analysis is flawed, and this is not actually true. And so I'll take you through. I wanted you to feel the heartbreak that I felt when this happened to me. So I want to take you through what the next steps were.
Wait, can I ask a question?
Yeah.
So did you include in your initial list of confounders all of the variables from that left-hand column that you?
Yeah, and many more.
Okay,
Yeah.
so all the ones that anyone ever thought were whatever generally accepted reason to
Exactly.
affect pancreatic cancer are already in your model.
Yeah, they were at when I was building the model, and they fell out because in our data set they're not significant confounders.
Okay.
And that's a good point to bring up again, is that you don't put everything that could potentially be a confounder. You actually see if it is a confounder in our data.
But I read a lot of times that people decide, a priori, to include a certain number of things that are widely accepted in the literature into their model. But in your case, you dropped them out.
Yeah.
Okay.
Different schools of thought, and different reviewers have different schools of thought. So there are reviewers who may read this and say, "Are you kidding me? You didn't put pancreatitis in the model? I'm not accepting this," and then you would
Okay.
put it in and watch your confidence intervals blow
Or you
up.
just respond to them when they say.
Right. If you have more clout than a medical student, you might respond to them and say, "Oh, you don't know what you're talking about. No, I'm keeping that out." We'll see how that goes. Yeah.
But we'll listen more because I don't know if I'm ready for the hard work.
Oh yeah, really? Yeah. Okay, you can leave.
No.
All right. So no, this is fun. But so basically, the reason this was flawed was because we're dealing with confounding by indication here, and what this is, it's a specific type of confounding in which, and it comes up a lot in observational studies, especially those in which we're looking at the effect of a medication. It's when the indication for prescribing that medication and the medication itself both affect the outcome of interest. And so this is a problem because in our case, we don't know whether that increased risk, right, 1.64, whether that was due to the diabetes they had or whether it was the effect of the metformin. It's because our referent group is filled with diabetics and non-diabetics, right, our cases that have used metformin also pull a diabetes association with them. And that is very difficult. You think, why can't we just put diabetes in the model itself? But you can't do that in our case because we're dealing with complete confounding by indication. In order to do that, you basically need people in all 4 cells of this 2x2 table. So you need people with and without diabetes that had and had not taken metformin. Unfortunately for us, obviously, everyone who was taking metformin has diabetes. And so you can't model out diabetes when all of your exposure is in one of the diabetes cells. So how do you deal with this? Well, you can subset your data into only the type 2 diabetics and only analyze them. And that kind of hurts because, I mean, in one sense, you get rid of your confounding by indication, and that's good. But on the other hand, we started with over 1,400 as a sample size, and now we're down to 170. And obviously that has ramifications for our statistical power. But we plow ahead anyway. And one statistical technique we can use to enhance our statistical power is the use of propensity scores. I don't know if we've talked about this. It was in the DCR book for us, just a paragraph, but I don't know if we ever really got to it. What it is, it's a way for an observational study to do its best to create a quasi-randomized situation. Basically, we have our eventual multivariate model. We've got metformin, a bunch of variables we're not interested in independently analyzing, and we've got that as it modulates pancreatic cancer risk. What we can do with a propensity score is take all of those variables that we're not interested in analyzing and group them and bundle them into one score, which ranges between 0 and 1 based on the likelihood that you received metformin, given a given iteration of all of these variables. And then when you adjust for that, you're adjusting for all the different variables, how they dictate your use of metformin. And just using those variables in the analysis, you can see the effect of metformin on pancreatic cancer risk while conserving your degrees of freedom. Another way to think about it is in a randomized trial, if your randomization is good, all of the potential confounders are randomized out, right? They fall out of your analysis. And the only difference is whether or not you gave someone metformin. In this situation, by adjusting for this propensity score, we're essentially taking all of the other variables, letting them fall out, and making the only difference whether or not someone received metformin or not. The only difference is that in this design, we didn't get to choose whether or not we gave them metformin. So with this, we can adjust for just the propensity score and metformin, and we get our final result. We model metformin use within diabetics. So our final odds ratio, 1.01, and recall that 1.00 is the null. And so what we see here is a non-significant, statistically significant deviation from the null hypothesis, which is, you may chuckle because of how much closer could you get to the null, but given that there is still conflicting literature, we still think this is a valid result, and we don't want to contribute to publication bias by not, acknowledging that this is what happens in our data. Now, an interesting thing that we could,
Sorry.
No, it's all right.
I don't know. You really use statistics for me. So doesn't it, how do you know how good your propensity score modeling is?
Yes.
And is that the whole?
Yeah, I took those slides out because it was getting very, very complicated. Basically what you can do is, you come up with that score, and it's supposed to predict whether or not you used metformin based on all these other variables.
It's all about how good it is at predicting.
Exactly. So their gold standard is whether they actually did or did not get metformin. And so there are stats you can do to predict that. And basically you create a receiver operating curve, right? So that like sensitivity 1 minus specificity, and the best is like, up with an integral of 1. And you can actually use the integral of that curve and how, how close it is to 1 to optimize the variables you put in. And you build a model, except your outcome isn't the risk of pancreatic cancer, it's actually metformin use. And in a similar manner, by an iterative process of putting in different variables, you can build an accurate model and look at the p-values of the integrals of your receiver operating curves.
We have the gold standard for everyone, which is that you know.
Exactly. Right.
Okay.
Anyway, so it gets quite complicated. I thought that.
Fair enough.
Yeah, I didn't know Lauren was going to be asking questions, but yeah, that's great.
Good question. I love propensity.
Yeah. But that's actually, I should just say that's a huge, it's a very controversial topic about what goes into propensity score. And it's all in the psychology literature actually, is where all this stats is done. Some people say you throw everything that could potentially be a confounder in there, and then some people say no, you use like a C statistic or a receiver operating curve to optimize your accuracy for propensity score, and then you have to check for something called exchangeability. Anyway, there's a lot of different ways of doing it, and I've seen different papers use different methods, but we chose one that we thought was the most accurate.
I was just wondering
has there been any efforts either in your study or in previous literature that has looked at diabetes as like a continuous variable?
Like duration of
based
diabetes?
on like, yeah,